House Healthcare. Welcome, and today we're going to continue our conversation around preventing workplace violence in hospitals. We did a walkthrough of this when we were here last, a week and a half ago, 2 weeks ago. And today we have in with us several people. I'm not sure if people are going to be testifying together or if we're just going straight down. So I have Elizabeth first, but Betsy, I'm not sure if you guys are jointly testifying.
Yeah, so we have a shared slide deck, but Liz can go first and then I can walk through mine. Is it okay if I share my screen now for her?
Absolutely, thank you.
Okay. Okay, send a request.
Oh, okay. I thought you were online, but it's only because you were logged in.
Oh, it's unless you want me to do
No,
what
no, no,
I
no, no.
teach. Your slideshow, I figured I would do it here, but look at all of you because it's a good conversation. Let's see. So she gets this going. Good morning. Thank you for having us again. We really appreciate the opportunity to continue these really important conversations to ensure safety in the workplace for healthcare workers. So I'm Elizabeth Kudo. I'm been a nurse for 16 years, specifically specializing in emergency medicine. And I am representing the Emergency Nurses Association of Vermont. I'm one of the directors as well as the Government Affairs Committee Chair. This work has been really important as workplace violence is now considered a pandemic in our field. And in order for us to move forward and be here in the capacity that is what is going to be needed in healthcare, we need help. So the epidemic of workplace violence. I'm going to speak a little bit to what the front line really looks like. We've talked about this a little, but not all of you have heard or know exactly some of the statistics that are actually happening or hear from those of us that are actually at the bedside trying to care for you when you need it. Local and national healthcare environment. So I'm sure most of you have heard some of the big news stories that have hit recently around violence in healthcare, the shooting in Pennsylvania, the Florida nurse that was beaten to unconsciousness in the emergency department. Kentucky, a nurse was punched, dragged, stomped. Chicago nurses were stabbed. 2 nurses were punched in Pennsylvania. Central Vermont Medical Center has had a patient accused of assaulting staff. These are not only what is happening. These are just the ones that make the news. They're bad enough to put a face in the media. And there are situations in which not all of this is reported. Unfortunately, workplace violence is greatly underreported because of the culture that's been created. So challenging statistics. And these are kind of, I think, when I started this work, when I was feeling it as a nurse, 16 years later, I was driving here thinking, what was my nursing profession like when I started? And I thought maybe I didn't notice this because I was younger and I was trying to figure out how to chart and not make medical errors and care for patients, or the census was lower, or I had nurses that were protecting me from this. And I realized that it's actually just consistently gotten worse to where we are now. So for me, looking up what the statistics are really made me validated what I felt every day at work. So the Bureau of Labor Statistics has healthcare and social services 5 times more likely to be assaulted than any other occupation. Press-Ganey reports that every hour, 3 healthcare providers are assaulted. Every hour, 3 of us. New York Times put out, did anyone see this? Mm-hmm. It was a really great video. Mm-hmm. Violence has become a daily occurrence in our hospitals. Stab kick spin on violence in America hospitals is out of control. This was like a really hard video for me because a lot of the people in the video, I've lived through this with. Mm. We now lead the nation days away from work due to workplace violence.
Does she take questions now?
Would you mind taking questions?
Sure.
Okay.
Why?
Why does Vermont lead the nation in days of work, doing work? What does these other states do that we're not doing?
That's a great question. One, there are currently 16 states that actually have workplace violence prevention programs. We're here because there are challenges federally to support OSHA putting in place national guidelines to support workplace violence, but what we need is a consistent standard across the state for facilities for protection of healthcare workers. So a couple of good questions. I'll rebuttal last 2 weeks ago. Not all hospitals have 24/7 security. Not all hospitals have a standard of security that is equal. So when I walked in here, there's a sign that say weapons are prohibited. You're subject to be searched. There's an officer that is armed walking around as a presence. It creates a feeling of safety. Not all hospitals have that. Some hospitals have none of that. And unfortunately, without the education around workplace violence, trauma-informed care, following up in response to violence, it continues the culture of this is okay. If we're not trained on how to deal with these situations as they arise, then it will only continue to get worse. So what we're asking is that we as a state regulate and protect healthcare workers in these situations consistently across the board for all organizations, for all nurses. Does that answer your question?
Well, kind of. I saw the list that we talked about the other day about everything you want to accomplish as far as training. Okay. I would like to think most of the hospitals have that list already up. Okay. And maybe some are a little weaker than others. Okay. But I don't know. I don't know if we're addressing the real problem.
I think it's multifactorial. And this is really challenging because for us, when we sit down, I could spend hours talking about what are the real problems driving the numbers up. So wait times in ERs. Wait times are consistently going up. Has anyone had a problem trying to get another primary care? What's your wait time to get your primary care, to a specialist, to get to an orthopedist, to get a CT, to get an MRI? A lot of the times those wait times result in people going to the ER. So we're going to see everyone, and TALA ensures that you get a medical exam. Most of us are going to actually do more than a medical exam and surpass that which is considered emergency care because we are trying to do our best to provide the care that you have come. There are unreasonable or the expectations of people when they arrive to the ER for, I couldn't get into my PCP, I've had an earache for a week, I'm now sitting here for 6 hours. I very much understand that you are frustrated. I can't get into my dentist. My tooth has been hurting. Nobody takes my insurance. I'm going to the ER. You're going to sit there for 6 hours. We're happy to be there to help you. But most of the time after that time of you sitting there for 6+ hours, people are frustrated. And then if you don't get what you're looking for, the type of care that you think you need, the referral you want, the test that your doctor sent you there for, oh, we can't get you in for a CAT scan today, or we need prior auth from your insurance, go to the ER, they'll get it done. It's clogging the system. The ER is turned into a funnel. So people wait, they get frustrated. The resources outpatient have been reduced. So detox facilities, rehab facilities, support services for families and children have all struggled with grants and funding and have closed their doors. So as those resources to discharge patients out to are decreased, those patients are all coming to the emergency room frustrated and tired, and I understand it. Chronic pain goes hand in hand with depression and anxiety. These people are already coming to us upset, and that is in addition to the emergency department patients, such as those having a heart attack, a stroke, a trauma. All of that, we are trying to triage, and that is what triage does. Who's going to die in 5 minutes, 10 minutes, an hour, next week, in a couple of years? And it's all based on our expertise. But when the system is overloaded and we're looking at 60, 90 patients in an ER, we're unable to keep up with it and people are getting frustrated, leading to increased episodes of violence. Same thing with behavioral health. Behavioral health is, again, we can talk for hours about that.
I'm looking ahead at your slides and it seems to me that you have a lot to come that's going to answer questions, and also we'll get to 259 and why that might be helpful to you. So let's let her complete the slides and then maybe we can hold questions when she's gotten through everything so that we're not jumping around. Is that okay? Thanks.
Okay.
Okay.
So who and why? So I started this work because, again, I was like really just struggling with watching my colleagues leave, good colleagues, with feeling that how many more days can I be assaulted and feel okay coming back? How do I be a leader and teach new nurses that this isn't a culture that we should accept, or that you need to stand up for yourself, when there's not really that structure behind us to reduce the amount of behaviors that we see? Again, there are situations that I've been hit. I will share, someone that is having a stroke that can't see out of the left side of their body, and I am trying to start their IV on their left side. I understand you're scared and you have no idea what's happening. And if you reach over because I've scared you or poked you, that is not assaulting me. If you have dementia, and again, this could go sideways too, there is a level of understanding that there is a diagnosis and that we are trained to evaluate behaviors and emotions and respond appropriately and clinically to those. Workplace violence has escalated past what is represented by a diagnosis. So I had a conversation with another colleague who wrote a great article about the overcrowding in ERs and the increase in violence. And I said, what do we do? Like, are you ready to high five and walk away? Great physician. And we both acknowledge that the burnout rate of ER providers is now down to 7 years. Year 5, we've just started figuring out what we can do. 7 years and we're ready to walk away. I'm at 16. So I said, okay, I'm gonna do a plea for help. And I use that word because that's certainly how it felt. And I said, let's start having conversations. Let's work together. I want to be there. I want to be the person that says we need to work together to have these hard conversations, to understand where your work meets my work and bridge the gap in the middle. I then realized as I started to have these conversations, oh, have you spoken to this person? Have you spoken to this person? Oh, this Act 24 is already working in this county, but it's not been initiated in this county, and started networking. And I met up with Betsy and Kate and Michelle and some other members of national global nursing organizations, the ANA and the VNPA. So we came together as a coalition as we realized we are all doing the same work. All of our specialty national organizations have the same stance on workplace violence, and we needed to band together in order to ensure that all of our voices were represented in the appropriate manner in the right setting. And here we are. So stronger together. We took an oath to do no harm. It's the nurses' version of the Hippocratic Oath is Florence Nightingale's oath. And no part of that oath included being assaulted. And considering that feels like part of a daily occurrence, and the statistics show it is a daily occurrence, it's an hourly occurrence, we need help with that. So increases in emergency department utilization, escalating violence against healthcare workers in all care settings, decrease in healthcare system capacity and workforce attrition due to ongoing violence create an untenable dynamic that reverberates through the healthcare system and broader communities. So where are we going in healthcare? This is the other piece. When you're watching a tidal wave come at you, I feel like most people would get out of the way. We as healthcare workers are watching the statistics around how many nurses we're going to need by 2030 and what we're really going to have. And as people are burning out because of reasons that we should really be working towards improving, we're adding that to the amount of reasons that people are leaving. So by 2030, all the baby boomers will have reached retirement age. That's an increase in utility of resources. It's an increase in the acuity of patients. In the U.S. Chamber of Commerce, 193,000 projected job openings by 2032. So the need's going up and the staff is going down. It's a negative 15,000 deficit. By 2030, it's expected that 42 out of the 50 states of the United States will likely experience shortages in nursing staff. It's going to happen. What we are trying to do is reduce the things that we can change to affect this. The nurses that are leaving, I had a nurse leave last year after being bitten for the umpteenth time by a patient that continued to be a behavior issue that we could not address, left. She left because of workplace violence. She is a person and not a statistic, but she is a statistic, but she has another colleague that walked away. Low retention rates, the burnout for us, as I mentioned, cost of living versus salary disparities, the education gap online, on our YouTube, Michelle, who was unable to attend because she had to step into a clinical role due to the lack of educators and has a couple students with her. That's why she couldn't be here. She is trying to, grow our own. I think we all want to do that. But unfortunately, most of us that are being asked to do clinical positions are doing it in addition to our own specialty, because being an educator in nursing financially does not meet a cost of living or the education that is required to have that position. And then our aging population. So of course, nurses are going to retire. There's a very large generation of nurses that are well respected and have paved the way for all of us. And I've enjoyed working with them and they've earned their retirement. But those of us coming into the field, over 50% by the age of 35, have thought about leaving within the next 2 years. So our proposed solution, again, very multifactorial. What is causing the increase into emergency departments and the increase into hospitals? We could certainly spend time talking about those and how those need to be addressed, how we need to put effort into recruiting and retaining nurses, into educating nurses. What we really need right now also is more of an urgent need to ensure that our state becomes one of the states that has a standard for workplace violence prevention. Improved recruitment and retentions, the right to safety. You all have the right to feel and be safe while at work. There is nothing that protects us. Employee support. Unfortunately, without appropriate training, again, trauma-informed care, workplace violence prevention programs, standards that are regulated statewide, unfortunately, we don't have the employee support that leads to this burnout and that leads to the increase in days away from work for our employees. Financial stability, the cost to train a nurse. I know that Voss, Devin, reported out that it's $88,000 to train a nurse. As I was reading into that, and again, as somebody that kind of does some of the budget stuff, I was trying to figure out where exactly that is. Statistically, it's 40 to 60,000 on training. So their salary while they're training, the classes that we're supposed to take as an emergency medicine nurse. I hope that everyone supports that we all have an increased need of appropriate education to be able to manage whatever walks in the door at any time. And we're really proud to do that, but that's at a higher cost to the hospital to support appropriate education. And then the 88,000, I realize, actually also includes what is needed to cover the FTE while training someone, but that is really only by generally staffed employees. That number is significantly high when these FTEs are covered by contract labor, which is a compounding component of these conversations with why nurses aren't staying or aren't staying as permanent staff. So The annual salary of a contract nurse is $125,000. It's approximately $50,000 over the Vermont national standard for a nurse. So incorporate that into what it takes a hospital to ensure that there are nurses at the bedside. That number, unfortunately, is significantly higher. So we have a financial responsibility to ensure that hospitals aren't just spending that money to have nurses burn out in the first 2 years that they're there. It's again, it's part of the big picture that is not going to make healthcare sustainable. Preserve quality for care of nurses. So this is my biggest point. I want to do this. Some people, when they hear my story, or, I talk to my family about what I do or what a day is like, they're like, how do you do this? And I think everybody in nursing goes into nursing for a different reason other than the money that we can make or, the accolades that we can get, because there are very few. We get into it because we want to be here to help people. Unfortunately, nursing's shortages and this burnout that we all experience increases our errors and mortality of patients. I miss the days where I could sit and talk to a patient as I'm trying to go through their education or their discharge plan. That no longer exists. And it's part of the reason that people are saying this isn't why I got here to practice. We want to be there when you need us. If you have an unfortunate day of being in the ER, we are trained to help you. But we're not going to be there if there's nothing to protect us. I'll hand it over to Betsy.
Thank you.
Hi, everyone. Can you hear me?
Yes.
Okay, great. So my name is Betsy Hassan, and I am currently the president of ANA Vermont. So that's how I'm part of this coalition. I too have been a nurse for 16 years. I have held direct care positions. I've been a nurse educator. I've been a leader. I've been a chief nursing officer of a local community organization here in Vermont. And I'm now the director of nursing education and professional development at the University of Vermont Medical Center. I have a doctorate in nursing practice. I also hold certifications as a nurse executive advanced and a nursing professional development specialist. I sit on the board as the elected representative for the Organization of Nurse Leaders, and I'm also a member of the Nurse Leaders in Advocacy through the American Organization of Nurse Leaders. So this is a front and center topic for all of those organizations and all of the organizations I've been employed with, as what to do with workplace violence against our healthcare workers. So my goal today is really to discuss the policy intentions and implications. I'll also get at why this is just one tool in the toolbox to address workplace violence. As Liz mentioned, this is really multifaceted, and we need a number of solutions to help us end this epidemic. So why is policy intervention necessary? One, we need to ensure that hospitals are accountable to their staff for workplace violence prevention. Without any sort of policy intervention, there's no way to really ensure that, that this is happening. We need consistent implementation of best practices. So as Liz mentioned, there's lots of variation amongst organizations in the state in terms of the resources that they may have or how programs have been developed, or even if there's a program or committee at all, which is really concerning when we know what the evidence and literature tell us to do to respond to workplace violence. We also want to increase equity in workplace violence protections. So this really is ensuring that all healthcare workers in Vermont have those same protections and resources when they go to work every day. We also know that the best way to address workplace violence is to ensure that our direct care workers have decision-making abilities in those recommendations, that administration or leaders who are far removed from the bedside or the clinical environment are imposing what they think is best when it really needs to be informed by the staff that are doing the work. And then we also want to ensure that there's an insistent or a consistent response to workplace violence victims. There are evidence-based practices at how to respond to healthcare workers in particular that are victims of violence. And then also there is Act 109, and we're seeking to expand that as this is an act relating to the safety policies for employees delivering direct social or mental health services. So there already is language to help some organizations who have programs like that, but this is really an expansion of that. I'll also say that OSHA is not necessarily a source of current evidence that is related to workplace violence prevention. That guidance hasn't been updated in approximately 10 years. So we're not really seeking to impose additional regulations on hospitals. Rather, we want to empower staff to identify those evidence-based practices that would be most effective for them and their organization to provide a safe work environment. So as I mentioned, this is just a review of the policy landscape. So as at the national level, HR 1195, Workplace Violence Prevention for Healthcare and Social Service Workers. This is for the federal legislation so that OSHA creates a standard based on, as I mentioned, outdated guidelines. The problem really with this is that it's been sitting in purgatory for quite some time at the federal level, as well as with President Trump's executive order for the 10-to-1 deregulation initiative. This really even places it more in purgatory, understanding that for every new regulation that is made, 10 need to be removed. There is for hospitals that are accredited through the Joint Commission, which is not all hospitals in Vermont, but some, there is a workplace violence prevention standard that most organizations have to meet when they are accredited by the Joint Commission. There are a number of professional organizations at the national level that have provided best practice toolkits. The American Hospital Association, American Organization of Nurse Leaders, Emergency Nurses Association. So these evidence-based practices are currently being evaluated and updated. And then lastly, at the federal level, there is the HR 2584 and S 2768, which is the Safety from Violence for Healthcare Employees, or the SAVE Act. And this is for additional protections for victims of assault in the workplace that are similar to airline workers. At the state level, first I want to say thank you for Act 24. This is another tool in the toolbox for us to use to prevent workplace violence and ensure that our workers are safe. And then other states, as Liz mentioned, there are, I think there's 8 states that have workplace violence prevention programs required by state law. And then most recently, Ohio will be implementing one in April of 2025. And then there are 38 states that have established or increased penalties for assault of a nurse, and we are included with that as well. So really, the crux here is that we really, at the federal level, we can't be assured that anything will move forward. And so it's important that we act as a state to protect our healthcare workers. So in terms of H259, an act relating to preventing workplace violence in hospitals, these are the key pieces of the bill, or the key provisions. One, we want to ensure that all healthcare organizations develop a workplace violence prevention program that's inclusive of an oversight committee with direct care staff representation. This is really important, that the people who are doing the work, like Liz every day, are a part of those committees and get to have a voice and a say in the decision-making about the best practice recommendations to put in place for their individual organization. It includes a security plan to address risk assessment, de-escalation, and defensive training plans. In terms of a risk assessment, this needs to be done at least on an annual basis. And then usually if there is an event that leads to a certain level of risk, they should also be done periodically to learn from those instances and what we can do better. There also is de-escalation and defensive training plans. So this is ensuring that staff have the training and education necessary to protect themselves best in the workplace. I think it can be assumed that all organizations may have something like this in place, but it's not. And it's not something that we should assume either for our employees that are going to work every day. Training in trauma-informed care to support employees as victims throughout the recovery and the legal process. We talked about this a bit before when Liz and I testified. but really that process for the immediate trauma that happens when someone is assaulted, and then the re-traumatification that can happen when you go through the legal process, because that process is long and it sometimes may come 6 months, 18 months down the line that you're actually being asked to come and testify or go through that process. And we need staff that can be trained in managing that trauma-informed response, as well as understanding the legal system with us to help navigate this for our employees. We also asked for an exemption from the certificate of need process for costs associated with workplace violence projects. This is really important should we need to install things like ballistic glass, visitor management systems. All of those types of things can be costly, and we don't want to have red tape really tie that up in implementing those best practices. We also asked for a commitment from AHS to work with hospitals to identify incentives and funding sources. This could be a key part that just as AHS has taken the lead in workforce development with the Healthcare Workforce Strategic Advisory Committee, this could be a critical piece for AHS to lead in workplace retention of those employees. And then lastly, this was excluded from the current version of the legislation, but we continue to advocate for a safe harbor for workplace violence prevention budget line item expenditures from the Green Mountain Care Board. Really, this is about ensuring that hospitals can respond in an agile and timely fashion, as well as making sure that they have the appropriate resources for staff to implement these initiatives. So really the time for us to act is now. As I noted, H259 is one solution to protecting our healthcare workforce. There's a need to keep people safe at work. We have a need to retain staff to ensure affordable access to healthcare. There's a need to recruit new Vermonters into healthcare with us in a safe way. And there's a need to not be the next national headline. So really what we're offering the legislature is the opportunity to put the solution in the hands of the healthcare workforce that we're so eagerly to try and protect and retain. Thank you.
Great, thank you. Thank you both. Any questions? Woody, did you have a question? And then I'll go to Leslie. Okay, Leslie.
It's really simple. You mentioned a pandemic in the beginning and my ears, sort of felt pandemic. So that makes me think of a more of an international kind of thing. Is this happening in other countries as well?
Yeah. So ENAs, we meet every year on a national global level. So this is a global point for us to be all addressing individually. Again, as we said, thank you. We have the opportunity of being in a state where we get to sit here and have these conversations and work towards change rather than feeling like we need to wait for some of those regulations to come through and protect us all, or other countries that don't even have that opportunity or have compounding situations that are affecting their healthcare systems. But this is global.
Is there a country you think doing really well that we could emulate or?
I could get back to you on that. That isn't something we've personally done a lot in regards to what the other states that have implemented are doing this to protect, and how that has really decreased the amount of workplace violence from behaviors that are adjustable. I would love to look into it globally. That would probably be opening Pandora's box for me, but maybe fun.
Well, I got my attention.
Yeah.
Thank you.
Yes, our H259 talks about workplace violence inside the hospital. I don't know whether our bill covers, the hospital grounds beyond the hospital. We think of the emergency room, the various wards, and perhaps that's maybe something we should look at expanding beyond just the hospital. It could mean, where are my notes? The entire facility, hospital blueprint for workplace violence.
I know we had a discussion around this when we did the walkthrough of the bill, and I thought that we had established that they're to create a security plan, and it's to pertain to any
Any,
Like,
any
any-
structure that's on the
any
hospital grounds.
structure, any owned, anywhere where there's staff, patients,
I know in my own
Interaction.
personal hospital, there's the primary care facility. There's also the various specialties offices that are generally separate from the hospital. You know, other like St. Johnsbury Hospital, they also have a nursing home facility on its grounds as well. So maybe we can look into ensuring that all those things are incorporated within this.
all right, well, we'll talk to Ledge Council about whether or not
Thank you.
we feel that's encompassed.
I appreciate that comment. I would like to say we all deserve, you know, safety in the workplace, again, to feel like the standards are set and we need to work towards the consistency. This is the tip of the iceberg. I think that a lot of the times, especially with this topic, or as we spoke, there's so many components of this that challenge what is increasing this violence. The question is often where to start. And I understand that. And when you look at where the highest rate of incidents and violence is, I think that is really just a great place to start, to say we are committed to starting somewhere. And we understand that this work has a long way to go, but we as our professional organizations also want to be here with you to help do all of that.
I want to put you on the spot, but all these trainings and everything, yeah, and I agree, they're all going to help, they're all going to be beneficial. But as far as you and your professionals talking, what else is needed? There's got to be some type of, is this going to be enough? Do you really think the training, it's a good start? But if it is a epidemic, what else is should be in the plans for your safety and everybody else's?
I think what we proposed is a great start. Again, tip of the iceberg. So there was a conversation about de-escalation versus essentially responding to an incident. We are trained to de-escalate. I've been doing this for a long time, and the staff that works with me and people that know me know very quickly what body stance I have, what the situation is from down the hallway. I avoid most altercations simply by using that de-escalation. The problem is that de-escalation training is often cut from budgets, or the standard for that de-escalation training has changed. So there are multiple opportunities for security training for us for de-escalation by different companies. They all come at a different price tag. Unfortunately, they come with different levels of de-escalation training rather than a standard. So we're often left saying, why am I taking this training, but you're taking that training, or this facility doesn't even have training or doesn't ensure that all nurses are trained. And a lot of the times the barriers are outside of our clinical control. So our ability to de-escalate and just be trained simply on that needs to be standardized. Our ability to walk into a facility and have a standard signage that says weapons and violence is not permitted here, citing laws that protect us. Those conversations that I have with patients at the bedside that say, does that really happen when there is a you cannot assault me sign? Open up a really great conversation that I like to have, because I'm very honest. I know you've been here for 3 hours. I know you're tired and you're frustrated. We are dealing with a couple other things, and I promise you that you will get the best care that I can provide when it's your turn. Having that standard is across and regulated across the board for this state and all of our organizations will make a difference. Having a standard that is regulated for a security presence 24/7, what is the level of the training for that security? Those inconsistencies at facilities, I heard somebody, you might have said it too, don't all hospitals have security? The answer is no. So the expectation and what people think happens and what we hope happens isn't happening, unfortunately. And we want to support our hospitals. We need the financial constraints that Betsy mentioned and the assistance to support our hospitals to do this. I don't want to turn around and implement programs that have to be complied by that will only shorten like staff cuts because they have to figure out where to take this from. I want to participate in incentives. I want to work with everyone to figure out how do we do this together financially to ensure that there is a standard met for everyone with reasonable financial accountability. And I want to support our hospitals doing that. It would be detrimental to impose a bill without support, without addressing that and supporting it. And to be honest, I mean, that would be a wish list without support or offers of recommendation.
Betsy, did you want to add to
Yeah,
that?
I wanted to share that having a workplace violence prevention program is not just training and education for staff and employees. You know, there are the constraints that Liz mentioned in terms of the amount of hours that some of this training happens in, which can be an additional, 16 to 24 hours for just de-escalation training per employee. But I also want to mention that when you look at the evidence and best practices, there are also things like visitor management systems. So that's knowing who's coming into your organization, making sure that they're going to the appropriate places, and that you can also have connections with local law enforcement to see if there's a no trespass or anything else that might prevent them from actually being okay to be in the facility. There's other things like metal detectors that can be installed in certain parts of the organization or at all entrances. There are things like locking doors or panic buttons that need to be employed for employees to be able to, press a button on their badge and have security come, barring if there is security staff. And so I think when we think about programs, it's not just a large investment in training and education for employees. It's also for the staff to be able to say, these are also the tools that we need from even a facility standpoint or from a technology standpoint. And so I just want to make sure that that's clear when we're talking about having a workplace violence prevention program.
Thank you. Daisy, and then Topper, did you have a question? Topper, and then
My question is around the trauma-informed care. And I'm looking at part of the bill that notes the security plan shall require that a hospital employee trained in trauma-informed care and victim support serve as liaison to law enforcement, yada, yada. I'm wondering if you considered having more staff trained in trauma-informed care, because I get the sense that you understand and appreciate that it's more than checking a box for HR and that it's a cultural thing to really have effect and benefit everyone, including patients. And I also know that a lot of staff and clinicians working at the hospital have been through a lot of trauma themselves. And if including some of that for staff themselves was something that was part of what you asked for.
That just reverberates what Betsy said about having a program. So not checking a box that says we have a metal detector, we have security, we have de-escalation programs, but having the bigger box, which is we have a workplace violence prevention program that includes an individual that is trained on that. Because we also, a lot of nursing care is actually based out of trauma-informed care, and we offer those educations all of the time. Betsy, can you speak to what was recently offered?
Sure. So we have at the University of Vermont Medical Center, we have 3 employees that are dedicated to workplace violence prevention training. And one of them started a program called Code Assist, which is all staff support in traumatizing events. And so this program is a 4-hour session on trauma-informed care peer response as well. And we've trained over 250 staff members at this point because we are trying to get at that cultural influence of how, one, are we responding to each other as colleagues, but also with our patients. I would also say that this is co-taught by one of our chaplains, recognizing the help that our spiritual care providers can also have in that space. And then also thinking about how licensed social workers may also be able to be a great person who's in that role that has knowledge of trauma-informed care, the clinical environment, as well as potential legal processes that they could support.
Those systems have been supported at other hospitals. So the other hospitals that most of us talk, we have relationships with our colleagues managers, our colleague nursing staffs. These are shared via Zoom a lot. So we'll get an email that says, please join this trauma-informed care being hosted by UVM. And it is shared as an opportunity because we don't have that program at our hospital. It is not something that has been created or regulated. So unfortunately, that is just something that for us as a savvy workaround as a nurse, we're just supporting each other to share. But ideally, in creating these programs that are supported and regulated, we would all have the opportunity to not only ensure that those doing the training are appropriately trained, but then moving forward, nurses also, all nurses that are on the front lines that are experiencing these situations, all clinicians. Again, we speak for the nurse practitioners. Again, sorry, Michelle isn't here. The PA colleagues that I really enjoy working with and my providers, everyone really that is facing these situations need to be informed and aware because this wears on us. This is what leads to burnout.
And I would hope that your leadership would also take part in those trainings so that they're aware of what you all are going through.
I think that is exactly what having the support of a regulated system that ensures that we're all doing the same thing and we're not trying to recreate the wheel with the resources that each of us has, ensures that we're all standing together on the front, that we want to support our patients and the quality of care that we give by supporting our employees that give it.
Thank you.
Robert?
Thank you, Madam Chair. Act 24. In Act 24, there's several things that are supposed to take place if certain kinds of violence takes place in the workforce. There's a couple of reports that are supposed to come to certain committees here. It appears to me, now, this is my own opinion, that what we set out here in Act 24 isn't working. So my question to you is, Act 24, you know all about it. Is it helping at all?
Yes. I'm going to jump beyond that, Betsy. And I think you would agree, and I'll have Betsy speak to her piece as well. We very much appreciate that that has set the ground and started this work. It's been great to work with Devin and Boss, who did that work with Senator Lyons, acknowledging that this needs to be supported and there needs to be repercussions. What is exactly where these conversations start. Unfortunately, there are some gaps, which is why we want to participate in these conversations with how it's implemented. The verbiage medically cleared is very challenging to those of us in the emergency department. It is very challenging and borderline impossible to those emergency medical services that respond in the field and also experience high levels of workplace violence. Because you cannot medically clear someone, even if there appears to be no medical need for assessment for their violence. And whatever is contributing to their violence, unfortunately, is not something that we can medically clear in the field, or depending on some of their diagnoses or the comments that they make in regards to self-harm or community harm, we're unable to medically clear them. So unfortunately, somebody that is homicidal or suicidal, reports homicidality or suicidality, walks out of their room, punches me, walks back into their room. They cannot be removed from the healthcare facility. They are cited. Unfortunately, again, Betsy can speak to this a little more. There have been challenges consistently implementing this. It is kind of stalled a little bit as well in regards to how each county responds, how each law enforcement agency responds, and then how state's attorneys are able to respond. So it's kind of created this culture where we can't do anything. So why did you call me here for this? And again, changing the culture to just say, we need that citation to ensure that these are being appropriately tracked, that is no longer like viewed as part of the job. I've had that told to me. I've had a patient pull a gun on me as I was escorting her out, and her expectations of what she wanted in the ER was not met. And luckily it was unloaded, and I was able to disarm her with another tech. And the police were right outside, as her verbal violence had already been escalating, and she was put in the police car, and we asked that she be charged, and we were told why it's not going to go anywhere. So we are also very committed to reaching out and all of these aspects that involve us at the bedside and how to bridge those gaps to ensure that this is consistent across the board, and we can do this, and there will be follow through.
That's exactly what I'm trying to get at.
Just Betsy might, I think Betsy wants to also.
So one, I would comment that Act 24 is another tool that we can use with workplace violence, but it's after the violence has already occurred. So really with H259, we're looking for those preventative practices that we know are guided by literature and the evidence in preventing workplace violence. So we're excited to have that work with Act 24 continue. I'm partnering with Voz and Wilda White from DPS to look at how we build out that consistent training for law enforcement and healthcare leaders and staff so that we're all operating from the same playbook in terms of how the policy is implemented. So there is forward movement on that. But I would say that, again, it's a response to violence that has already happened. And we're asking for more preventative practices.
Okay, just quickly, are you able to tell us whether or not anybody has been arrested and gone through the court process? And because you mentioned there has to be some kind of a consequence for what they're doing. Do you know from the local level, an incident that may have happened with you or somebody else where the process outlined in Act 24 was followed and somebody's in jail or in treatment for something?
Treatment, yes. So I do know that there are state programs, especially in Lamoille County, in regards to a deferral process. So patients that are charged with assaulting a healthcare worker can go into this deferral process where they have to acknowledge that what they did was wrong, that they committed that crime, and then they go down this other route of, they call it a rehab process. So I do know that that is working. I also, correct, to Betsy's point, it is reactive, but in educating about Act 24, because a lot of healthcare workers don't know it or understand it, I've done a lot of education around it. We're also able to use it when we talk about those signs that say violence is not accepted or will be tolerated. So being able, and I've used this as a tool in my toolbox with de-escalation, being able to say that this state has Act 24, which does not allow you to assault or threaten a healthcare worker, very quickly escalates those that have a behavioral component in regards to an emotional reaction. And again, I think changing the culture that most of us can stand up for ourselves professionally in that setting and in those circumstances, that helps us feel like we have something standing behind us to do so.
Good. Just for the committee, when we need to read those two reports that came out of Act 24, because we may want to add on to 259 some of the recommendations in those reports.
Actually, it's a good Kristen, good use, and because I'm sitting here kind of going through VPQHC's recommendations. Could you send that report? It's entitled VPQHC report under S36 from January 15th to 24. Could you send that to the whole committee? So we all have that, and I encourage everybody to look at that, because some of the recommendations in that are in.
I participated in that.
59. Oh, good.
It was really a privilege to be tagged. Again, the conversations that are happening don't always include or often include us at the bedside. So it was a really great conversation I had with VPQHC, excuse me, thank you.
Can we put that on our website? Yeah, maybe for today, yeah.
It's.
We'll send it out and then we'll post it as well.
Posted under reports already, and I already did send it out, but I can redo.
That's great.
Yeah.
Wendy,
I just had a quick question. This all just, like you said, it seems more reactive to me, feel safe in the workplace, you need to walk in feeling safe. What else is there that, like you mentioned a panic button?
Yeah. So some facilities have panic buttons. Again, the consistency of what a panic button is, what response is initiated. Each organization is kind of left to determine how that happens, whether it's maintenance that responds, whether it's the emergency department, because they're 24/7 and it's a small facility, is the one that responds to their own emergency. These are reactions most often to incidences where they say, oh, we need a panic button, or we need double swinging doors, or we need a split door. Where again, we are here asking that moving forward, it is proactive. We understand that there is a reactive work that has already started, but you're right. You would think that everyone walking into here, into Starbucks, into the grocery store, into an airport, all expect to feel safe going to their jobs, and that is not consistent for healthcare workers.
thank you. I think I'm asking a question which I already know the answer to. Okay, but a lot of other committee members' questions, I would like you to reiterate. I think because Alan had said something, and then Wendy just sort of alluded to the same thing. Can you point out to us currently the disparate security plans, resources, the difference between various hospitals in the state of Vermont? Are there ones that have better plans than others? Are there ones that don't even have security? Can you just sort of hone in on that a little bit? Because I want to make sure people are really aware that the reason we're looking at H259 is to sort of come up with a clear, cohesive expectation that all hospitals in the state should be working under the same parameters.
Thank you, Alyssa.
So if you could highlight some of the differences perhaps without naming names.
That is what made these conversations start. Why do I walk into one organization and I am a triage nurse that is protected by bulletproof glass, yet I walk into another organization and I have the same risk, but I do not have security, a metal detector, or bulletproof glass? Do I want to be in a field where I need to sit behind bulletproof glass? No. Is that the reality of what is happening? Yes. So not all facilities have bulletproof glass. Not all facilities have a standard for security. Often, as we're navigating the financial barriers to healthcare and FTEs and the distribution of needs, we are not equitably deciding where that security goes to or what security looks like. So is it the housekeeping staff? In some facilities, it's a housekeeping staff. It's the maintenance staff. It is someone that is trained in a dual responsibility because we're doing the best that we can to figure out financially what FTEs have been approved financially or where to steal an FTE from. So we're robbing Peter to pay Paul to ensure that there is security. Larger facilities that have implemented security don't have the right amount of security for the amount of space that they cover. So while it's great to say I might have 24/7 security coverage, one security officer covering a multi-floor, facility organization is not enough. Workplace violence programs, so individuals in HR that are trained in this, crisis workers that are trained in the response for trauma-informed care for nurses, de-escalation programs consistently in regards to Moab versus Evade versus John Smith's security company, consistently medical record systems that allow an alert for a no trespass system. No trespass systems. So that was something that do facilities have a consistent way to alert if there is a patient who has been no trespass. So a no trespass means that we still have to provide you medical care, but once your care is done, you need to leave the facility. There are not consistent systems in place or policies in regards to how each organization manages that, which leaves the clinical staff pretty blind to who's in the building. Security cameras, individuals watching the security cameras. So again, the gap that we have acknowledged and said this work is worth doing is that we are not consistently protected, and we feel that there should be a consistency, as well as the other states that have worked towards this and those that are pushing the federal regulations to make this consistent in our state. And we want to participate with that. And it needs to be with the support of everyone here and VAS, who is supporting it, as well as AHS in regards to what incentives and financial contributions are going to be allocated to ensure the equality across each organization.
I think Daisy has a comment, and can I ask her a question real quick about our agenda? I have John Hendrickson and Michelle Wade. Are you guys presenting?
No.
Okay, great. So we're not running as far behind as I thought we were. Go ahead.
I don't want to take up more time, but I just want to say it has been so hard to sit and listen to you, because I'm infuriated that Vermonters are paying what we are for healthcare today, and the people who are doing the hardest work and helping us perhaps the most can't be guaranteed or even just allocated the resources from that same system to do their jobs safely. And I'm sorry that that's not being done for you. You don't deserve that. And I'm really sorry, and thank you for letting us know what you need to do your job.
We appreciate that. That's why we're here. Healthcare is challenging. You guys have quite the project to work towards how to make your guiding principles applicable in the state. I think we're all committed to understanding that we can get there, but identifying where healthcare has gone upside down and how we can all participate together to ensure that the right resources are allocated equally and they're regulated, and we're supporting each other and we're supporting our organizations. Because as I said, implementing regulations that aren't attainable to facilities could potentially only lead to facilities closing, which will only increase the lack of access to healthcare for our state, unfortunately.
I'll just say that, we've spent years in this committee talking about workforce retention. And usually it's a money question and it's throwing money, but people's work is motivated by more than money. And I can't imagine staying in any profession where I feared going to work every day. So,
And
Alan.
basically, that's what I was gonna say. I guess, what's the percentage of workforce violence that maybe in just your hospital, or if in the state? Is it an everyday occurrence, every 4 or 5 times a day? Okay, so the issue I have is, I'm saying I don't know if this training is even enough. I want to make sure that we do not lose nurses after 2 years, 3 years, or 7 years. We are taking some wonderful people that have decided to be healthcare nurses and whatever. And we're losing them because I'm saying a very few that we're dealing with that I don't know if we're supposed to or should. I'm tougher than most.
Well, I'll admit I'm tougher than most. But I will also say that again, to my point, we all do this not because we're getting the accolades or we're being paid a lot of money. It's because we want to do this and we do it together. Emergency medicine especially is team-based. Some may say we have a dark sense of humor that gets us through it, and we probably do. But that being said, you know, if you've ever sat at a dinner table with a nurse, we have very different conversations when we come home from work. But we are there to help people in their most vulnerable and dire time of need. The work that we do and the team that we do it with is what keeps recruitment and retention in facilities. So if the shift can go from what are the priorities to simply do our job, feeling safe in our workplace, appropriate resources for disposition or appropriate resources within each facility, those are all really what are going to start turning the ship towards what will continue to keep us doing what we were all called to do. So it seems silly sometimes, but again, encouraging and supporting those next to you and smiling at the end of the day with a team that you appreciate working with that feels protected and supporting is exactly what will keep us all doing what we're doing.
Betsy, did you want to add?
I just wanted to highlight the impact of a healthy work environment, which is really what H259 is striving to help with. And in October of 2022, the National Academy of Medicine put out the National Plan for Health Workforce Wellbeing. And so addressing all of those cultural components that helps build resilience and well-being within our workforce is what's going to keep people here and keep people retained and at the bedside providing care. And so I think that as we think about H259 in the broader health system, this is a step towards creating healthy work environments with a foundational set of best practices that we can implement at all our hospitals. And so I think that this is a real moment that we could make some positive change in addressing that healthy work environment that we know will keep people at the bedside and address culture.
Great. Any other questions? Thank you. Thank you both so much and from around the room.
Thank you.
So next we have Matthew Sutter from Green Mountain Care Board.
Network with Stephen City.
Thank you very much.
Thank you.
Thank you for joining us. So there is a piece in H259 that pertains to hospital budget review and hospital security plans being exempted. So really wanted to get the board's thoughts on this.
Thanks. First, let me preface by saying how important we think this work is. I can speak anecdotally to myself. My wife and I had our daughter last summer, and going to CDMC and having to kind of just check in through metal detectors and stuff in the early morning made it kind of real and jarring, the stories we've been hearing about workplace violence. So very appreciative of the work you guys are doing here. I think our concern is more of a technical nature around the budget review language. Currently in the statute in that section, all the items typically refer to general criteria the hospitals have to meet in submitting their budgets. So consistency with the health resource allocation plan, promoting efficient economic operation of the hospital, things like that are not they're not vague, but they're general enough that they allow some discretion and be able to view the hospital budgets holistically. The way the language is written, I think currently in this bill, it's more prescriptive, and I believe there's language around like shall allocate sufficient funds for the plan. It would be, I think, the only part of the section that has that sort of prescriptive language. And it raises some concerns about the budget review process. Some situations, if I could give you an example, like let's say a hospital comes in with a budget that doesn't allocate sufficient funds. As the board, how would we review that? Would we require them to cut expenses somewhere else? Are we prescribing where those expenses are to be cut? Would we require them to raise commercial rates in order to cover the full amount of the plan? So it's more the knock-on effects of requiring that shall language. From my perspective, I think we definitely should be considering it as part of the budget review process, but I think the language could be changed to be more consistent with the other items under that section. So maybe the board reviews or budgets are consistent with the workplace violence plan established by the hospitals rather than prescribing fund allocation.
So you're talking about the very last section piece, number 7 of the bill.
Or is it section 2?
Is it section 2? I mean,
I'm looking
I was
at
looking at section 4. Was section 3?
Forgive me. I thought it was
Yeah, sorry.
Let's get oriented here.
Do you have alternative language?
I don't have it with me right now, but we can submit it as soon as possible this evening.
Okay.
So, yeah.
Yeah, if we could have alternative language, that would be fantastic. Oh, Lori?
We need to put a timeline on that.
Yes, this evening you said.
Yes, we can submit it this evening.
This evening, yeah.
Oh, I'm sorry, what section were you talking about?
Forgive me, I don't have the actual bill open
Oh,
currently.
sorry.
Thought I do.
I think somebody's holding the bill over.
Section 3,
Oh, I saw section 4.
and I saw section 2, so.
So we'll get the language and we'll put it in with.
Okay,
If there's no other question, thank you for having me. That's all we have.
we'll get it clarified, and additional language would be great. Or compromise language.
Thanks so much.
Any questions? Other than which section it's in, which clearly none of us are gonna be able to answer.
Yeah.
All right, thank you so much.
Thank you.
We are going to take a break. We actually have a break scheduled until 10:45. Do we know, I'm sorry,